Welcome, and thank you for joining the COVID-19 Vaccination Parent and Guardian Information Session. My name is Jonathan, I'm from Public Health. Joining me this evening is Adele, who is also from Public Health. And we also have other staff working behind the scenes helping us with tonight's session. We're excited to have parents and guardians from across Waterloo region joining tonight for our talk about COVID-19 vaccinations for ages 5 to 11. As you all know, there's no shortage of information about COVID-19 vaccines out there, and this session will be your opportunity to have your questions answered by an expert on the topic that can provide you with reliable information. Before we proceed, I just want to outline some details about how the session will run. So participants' microphones will be muted during the session, and if you do have questions now or during the session, there is a button along the bottom labeled Q&A, and after clicking that, please enter your questions in the comment box, and we have set aside a question and answer period where we'll be going through as many of the posted questions as time will allow. If we don't get to your question, you can submit a question to the Region of Waterloo website. On the COVID-19 main page, there's a link to submit a question, or you can call the Region of Waterloo main phone number as well. Also, to let people know that we are recording this session, and we'll be posting this on the Region of Waterloo YouTube page later. As a disclaimer, if you're viewing this presentation at a later date, there may be more recent information, so some information may be out of date. So the content for tonight's session will focus on the Pfizer vaccine for ages 5 to 11, vaccine effectiveness, COVID-19 health effects, where and how to book an appointment to get the vaccine. What we won't be covering is COVID-19 procedures within schools or public places. Tonight, we are delighted to have an expert in the field, Dr. Kelly Grindrod, who will be providing information related to the vaccines and what is important for both parents and guardians to know. Dr. Grindrod is an associate professor at the University of Waterloo School of Pharmacy. She's also a licensed and practicing pharmacist and is the pharmacy lead in the region's vaccine efforts. She was also involved in the health sciences campus clinic where she vaccinated many patients. She's now working on developing information tools to help people make decisions about vaccines. Dr. Grindrod will first present, and then Adele is going to discuss how to book an appointment and clinic locations. And then Dr. Grindrod will be answering your questions during the question and answer period. So I'm now going to hand it over to Dr. Grindrod. Thank you for joining us this evening.
Thank you very much. Thanks for having me. So if we can go to the next slide, I'll be talking about COVID-19 vaccines specifically for ages 5 to 11. Now, some of what I talk about might be relevant for teens if you've got older kids or even yourself, but the focus is going to be on 5 to 11-year-old kids. So in terms of conflicts of interest, I think it's really important to start up front with I have no conflicts of interest to declare. I have no relationships with pharmaceutical companies. And this is a common question that I get. I actually don't take funding from pharmaceutical companies. I never have since I've been a professor, even for the research that I do. The closest I get to pharmaceutical companies is occasionally when we're working with the vaccine and maybe we have a question like, how many times can I go through the rubber stopper on the top of a vial, or a syringe got bumped, can I still use it, or some sort of stability information. We'll call up the pharmaceutical company to ask questions about the product, but we don't do that when we're looking at things like safety and efficacy and the things that I'm talking about in the presentation today. So I want to make that very clear. I really don't have a relationship with pharmaceutical companies, and I do that on purpose because what I'm doing often is helping people make decisions about vaccines, and we want to keep that as free from bias as possible. I also didn't receive a speaker's fee for this activity, and actually for the work that I do with the region, I'm not paid by the region for that. So I'm actually paid by being a University of Waterloo professor. And in my role as a professor, this is some of the stuff that I do. And a lot of this is also on my own time. So again, I'm not paid by pharmaceutical companies. I'm also not paid by public health. So there's 4 things that I'm going to go over today. The first is a review of COVID-19 and the vaccine uptake in Canada. The second is vaccine preferences among parents and guardians. The third is COVID-19 vaccination in kids, the latest science, what we know so far. And the fourth is, and I'm going to end with this, tips on managing pain and fear during vaccination. So if you've seen a presentation by me, I often start with a slide like this. It's from my colleagues at a group called 19 to 0. And we've been doing these presentations since about February of this year, or maybe even January, back when there was only about 1 million doses that had been given. Now we're at over 60 million doses of the COVID-19 vaccines have been given in Canada. And in terms of the eligible population, which now includes kids 5 and older, 83% of eligible Canadians have had at least one dose and 80% have been fully vaccinated. Now, if you look at this map, the blue numbers are first doses and the red numbers are 2 doses. And what you see is that in most provinces, we see about 85% of eligible people, so 5 and older in those provinces, have had at least one dose, and about 80% have had at least 2 doses, with the exception of Alberta and Saskatchewan and Nunavut. And in particular, Alberta and Saskatchewan have had higher virus rates. And so they're getting the vaccine there at a lower rate, but they are also getting some immunity from the people who do get COVID and have survived COVID. So it's slightly different situation there than we have in some of the other provinces. So when we're looking at the Pfizer vaccine for kids, so this was approved in the US on November 2nd. Now, Pfizer actually applied to the US a little while before it applied to Canada, which is why it was approved there first. And as of December 1st, so as of yesterday, over 4 million doses of the Pfizer vaccine had been given to kids 5 to 11 as a first dose, and just under 500,000 doses had been given to kids 5 to 11 as a second dose. Now, in the US, they're using the 21-day interval that was studied in the research trials. So what we're seeing is, about 4 weeks ago, they started their vaccine campaign in the 5 to 11. We expect in the next few weeks, the majority of those 4 million kids will have had their second doses as well. This is important when we talk about things like myocarditis. So I know a lot of people are concerned about myocarditis as a risk with the vaccine, because that was something that came up when we were vaccinating teens. So what we're actually looking at is myocarditis tends to happen within about a week of the second dose. So we actually expect, if we're going to see it, we don't expect it, but if it's going to show up, we actually should start seeing it in the next week or so. Now, if we compare that to Canadian data and the Canadian approach, it was actually approved about 2.5 weeks later in Canada on November 19th. As of November 30th, we actually don't have Canadian totals yet and how much vaccine has been given to kids 5 to 11. That gets released on Friday, so we'll know that tomorrow. But in Waterloo region, for example, there were just under 8,000 doses that have been given to kids between the ages of 5 to 11. In Canada, we're doing an 8-week interval. So NACI, the National Advisory Committee on Immunization, has advised an 8-week interval because those 2 doses a bit further apart provide stronger and longer lasting immunity. So we know that from the early experience in Canada, but there's also some data to suggest that those 2 doses further apart lower the risk of myocarditis. So that was something that we learned from the teens and the early 20-somethings. So in Canada, we're actually not due to start giving second doses until mid to late January. So again, by the time we're giving second doses here, we'll probably have a significant amount of data, real world data from the experience in the US. So the vaccination rates in Canada are high across most age groups, except for under 12s. And that makes sense because we just got the approval last week for the under 12s. But if we look at this table, the first column are age groups, 0 to 11, 12 to 17, and so on. The second column is people in that age group who have had at least one dose. And the last column is people in that age group who are fully vaccinated. And what you notice is if we look at 50 and older, so 50 to 59, 60 to 69, 70 to 79, 80 and older, about 90%, upwards of 95% of those populations have had their first dose. And about 88%, up to about 93% of those populations are fully vaccinated. So we have very high vaccination rates in the older populations, especially in the 70 plus, 80 plus groups. If we look at the younger groups, so 30 to 49, for example, those tend to be a little bit lower, so 18 to 39 as well. They tend to be a little bit lower. So first doses are 85, 86%. Second doses are closer to about 80%. If we look at the 12 to 17 group, so this was approved late May for 12 to 17. We did a lot of vaccinating of the teens through the summer months. So 87, 88% of the 12 to 17-year-olds have had at least one dose, and 83% are fully vaccinated, have had both doses. So we expect the number in the 5 to 11 group also to pick up over the next, say, 6 to 8 weeks or so. Now, this is a useful graphic from the Ontario Science Table. So the risk of infection, hospitalization, and ICU admission are much higher among the unvaccinated. One question I often get, and I'm sure you might have this question, you might have heard this question as well, is that if vaccines are so good, why are vaccinated people getting sick? So what this shows us is we've got 3 bar charts and you've got 2 columns. There's the orange bar and the blue bar. The orange bar is per million people who are not vaccinated, and the blue bar is per million people who are fully vaccinated. So what you see is if you take 1 million people based on Ontario data right now, 1 million people who are not yet vaccinated, about 209 have COVID right now, about 111 are in hospital, and about 79 are in the ICU. If we similarly take 1 million people who are fully vaccinated in Ontario right now, about 37 have COVID, about 7 are in hospital, and about 2 are in ICU. Now, these numbers are really important because, if we had a perfect vaccine, these numbers would be 0. We'd have the regular numbers in the orange column, and then we'd have 0 for the blue column. But we don't, so we're having some breakthrough infection. And a lot of people are asking, well, why are we getting breakthrough? If these vaccines are so good, why are we getting breakthrough infection? So we're looking very closely at those blue columns to find out what they mean. So for example, in those blue columns, what we're seeing is older populations. So people who are 90 or older, 80 or older, 70 or older, people who have serious illnesses. So they have cancer and they're going through chemotherapy. Maybe they've had an organ transplant. Maybe they're taking certain medications that suppress their immune system, like the biological drugs for rheumatoid arthritis or MS or any of those conditions. So in those cases, we're seeing those groups come up in the blue. As we also watch things like this new variant of concern come in, Omicron, we would want to watch there to see, are we having more breakthrough infections when it's the Omicron variant or not? And this is actually where you might start seeing third doses come in. So if you recall back earlier this year, late summer, early fall, we had third doses announced for people who had cancer, going through chemotherapy, people at transplant, and people with some of those immunosuppressing medications. They were offered a third dose 56 days after their second dose. So it wasn't really a booster, that was actually a third dose. So where most of us who had healthier immune systems had 2 doses, to get the same effect in people who had weakened immune systems, they were given 3 doses. So that was not a booster. That was what we call a primary series. A lot of people had a 2-dose primary series. People with weaker immune systems had a 3-dose primary series. So we were watching that blue column to see what was showing up there. Similarly, we're starting to see more older people show up there, and healthcare workers who have been vaccinated their 2 doses close together a long time ago. So as they start to show up, it's sending the signal that it might be time for a 3rd dose for these particular populations. So that's what this is showing us. It's not that there's a problem with the vaccine, it's us learning about the vaccine as time goes on. This is a graph from Public Health Ontario. So this was just from a couple of days ago. And what it's looking at is on the left, you see it's the rate of COVID infections per 100,000 in the population. And along the bottom, what you see are age groups. So there's the 0 to 4 age group, the 5 to 11 age group, the 12 to 19-year-olds, 20 to 39-year-olds, and so on. And what you see is that the rate of COVID infections per 100,000 of the population is highest in the 5 to 11 age group right now. So for the 12 and older, as we've just already looked at in the other trial, we have fairly high vaccination rates, and that's probably what's protecting the 12 and older. The 5 to 11s are the ones that have gone back to school. A lot of them are back in sports and activities. So it could be hockey or dance or music lessons or whatever else that they're doing. So they're back out there. There's still mask mandates and things in place, but what we're hearing is a lot of these infections are also coming from family gatherings where families are getting together, but the young ones are not actually vaccinated. So we actually see the highest rates of infection by far in the 5 to 11 group. We don't see as high infection rates in the 0 to 4 group. It might be because a lot of them still aren't, they're not in school yet. A lot of them may not have returned yet to daycare and things like that. So they don't seem to be as high risk right now as the 5 to 11s are. Now, this is a survey that was done by colleagues of mine at 19 to 0, where this is a standardized survey that was done, compared, it was meant to represent the Canadian population. So it was adjusted for things like age and race and location and so on and so forth. And what they asked was, suppose one or more of the COVID-19 vaccines available for individuals 12 and older becomes available to children under 12, would you have your child vaccinated? And what they found was about 2/3 of Canadian parents or guardians intend to vaccinate their child once a vaccine becomes available. Now, that might be you on the call right now. You might be planning on this, but you just haven't done it yet. But about 16% were unsure. So that might be you. You might just have some questions. And about 19% have no intention of doing that. And when we look at the people, when they're asked a bit more, okay, so you're not going to do it, well, why not? Some of the reasons that they give are concerns about safety. So just under half are worried about myocarditis or problems with fertility or other safety concerns. About 1 in 3 are concerned because they feel that there's a low risk of serious outcomes in COVID in children. So, is it worth it to get the vaccine? About 12% have a really valid question about, well, my kid already had COVID, so they have some natural protection. So do they still need to get vaccinated? And then there are various other concerns that came up much less often. So the COVID vaccines do 3 things. The first is that they lower the risk of getting infected. So that's for all of us, and that's even for kids. They lower the risk of being contagious, and they lower the risk of complications like severe illness, hospitalization and death, long COVID, and MIS-C. And I'm going to go through what MIS-C is in a minute here. So you can still get COVID if you're vaccinated, but you're less likely to get it. You can still be contagious if you get COVID and you're vaccinated, but you should be contagious for less time. So your body actually recognizes it faster and clears the infection faster. So you're sicker for less time, which means you're contagious for less time. And if you are getting COVID, if you do get COVID, you should have less severe illness. So the vaccine should protect you against severe illness requiring hospitalization, for example. So if you're fully vaccinated, which means 2 doses plus 2 weeks after your second dose, dose 1 lowers your infection rate by about 30 to 50%, and dose 2 lowers your risk by about 80 to 90%. And the big question, of course, right now is with this Omicron variant of concern, if this is the same or if it's different. We won't know for another couple of weeks. We're hopeful that the vaccine has a similar effect there and that it's not that different, but we'll need a couple of weeks before we have good answers there. Also, after 4 to 6 months, older people do tend to lose some immunity. So you're hearing a lot about waning immunity. We don't know yet if it's the same for younger people. So when we talk about we need long-term research for the vaccines, it's actually this that we're mostly looking at, is how long and how good our immunity is. But there still seems to be strong protection for severe illness. So even when we have waning immunity, where people might have breakthrough infections, it seems to be doing a pretty good job protecting against severe illness, hospitalization, and death. So I like this graph. I'm going to take you through it. I've used this in other presentations. I worried the first time I used it that it might be a little bit complicated, but after I've given these presentations, some people have said to me, okay, that actually started to help me make a lot more sense of these vaccines. So when you're first vaccinated, or you have a COVID infection, or you're vaccinated against the flu and have a flu infection, anything like that, you have a lot of antibodies. So your body makes a lot of antibodies. It has very high levels of antibodies. It clears the infection, it gets rid of it. And for a while, those antibodies stay in your body. But antibodies are living things, and they don't stick around forever. They have a lifespan. And this is important because immunologists like to say that if we held on to every antibody we ever made, our blood would be as thick as molasses. Our bodies are not meant to have all the antibodies we've ever made present for all of time. So after we've had that vaccination, especially second dose 2 weeks after, or we've had an infection like COVID, we have a lot of antibodies in our body. So we have something very close to what's called sterilizing immunity, which means we're like Teflon. We could be exposed to the virus. The second we're exposed to the virus, our body's got those antibodies there. It's cleaning it up. It's getting rid of it. So we don't get sick at all. But those antibody levels start to fall. There's different kinds of antibodies. They have different functions. They're located at different parts in our body. So at one point they might be in our nose, but if they're not in our nose anymore, for example, the antibody levels have dropped a bit and we're exposed to COVID, it might come into our body. A virus starts to replicate in our cells. That's how viruses work. And then your body, if it doesn't have as many antibodies, might respond. There might be some, and it responds and it manages to clear it. But in that time, you might have had just enough COVID that you actually managed to test positive, but you had no symptoms. Those antibodies might fall even more. If it was a little bit later, now let's say it's a few months that pass, you have less antibody immunity and you're exposed again. Now what's happening is your memory cells are the ones that have to recognize the infection and say to the body, hey, make more antibodies again. And so when you have them, you might, in that case, by the time the virus gets in your body and starts to replicate, you might have some mild cold symptoms. You might have a stuffed nose, sore throat, maybe lose your sense of smell a little bit, but your body's on it right away. Those memory cells are there, the T cells and the B cells, and they're telling your body, make lots of antibodies. They come in, they clear out the COVID, and you just have a mild infection. If those keep dropping, or maybe our memory cells aren't functioning as well, it takes longer and longer and longer for us to respond to that infection. What we want, no matter what, is when we give somebody a vaccine, at first they're going to have that sterilizing immunity. But what we really want in the long run is no matter what, and when they're exposed, their body responds in enough time that the virus might give them mild to moderate cold symptoms, but it doesn't go in their lungs and give them a pneumonia. It doesn't make them sick enough that they need oxygen. They can fight it long before it causes death. That's the goal of vaccination. And interestingly, even vaccines like smallpox and the polio vaccine don't necessarily provide this perfect sterilizing immunity either. So it goes to show, even when you have a vaccine that doesn't do that gold standard thing that you want, that amazing sterilizing immunity, you can still really beat back a virus, even with vaccines that have a bit of waning immunity. So immune systems are like spectrums, and they can vary over time. These are very complicated systems, but I think one thing it helps to recognize is that immunity is not black and white. It's not on or off. It's not working or not working. There's a whole bunch of things involved in immunity, and there's a whole range of immunity. Okay, next slide, please. So COVID in kids can be serious. So in most kids, it's a mild infection, but it certainly can be serious. It can be severe. So kids make up about 20 to 30% of COVID cases in most of Canada and the US right now. In the US, more than 3.8 million kids have been infected. About 500 kids have died. We've controlled COVID much more tightly in Canada, so we have less than 20 kids who have died, which has been good. But COVID is not the flu. COVID right now is currently one of the top 10 causes of death for kids. In Canada and the US, kids account for about 2% of hospitalizations. About 2,000 Canadian kids have been hospitalized so far, so just below that. And of those hospitalized, about 1 in 3 had no other conditions. So no asthma, diabetes, or anything like that. Kids who are otherwise healthy could also be hospitalized and have severe illness. So one thing that's important to note is, and a lot of people might not realize, is polio. For 99% of kids who get polio, they don't necessarily have the polio, the paralysis, the poliomyelitis, or the paralytic polio. And so when we think of even polio, which we think of as a very severe infection, the iron lung, the paralysis that happened in kids that in some cases persists into adulthood today, that was really only about 1 in 100 cases that really had that too. And this was a slide that came up when the US CDC was reviewing the evidence for approving the 5 to 11 vaccines. And it was quite helpful, I found, to consider, when we use vaccines and what we're trying to prevent. So these are all vaccine preventable illnesses. These are things we give vaccines for now. And what this is looking at is, prior to the vaccination, how many deaths were there per year on average from this condition. So if we start with hepatitis A, prior to the vaccine, so in the years of 1990 to 95, on average, under the age of 20, there were 3 deaths per year. For meningitis, so meningitis is one of the ones we vaccinate for, say the grade 7 vaccines, for example, includes a meningitis vaccine. Looking at the 11 to 18-year-olds between the years of 2000 and 2004, about 8 on average died per year. If we look at chickenpox, so 5 to 9 years old, between the years of 1990 to 94, so before vaccine, about 16 died per year. For rubella, which a lot of us haven't seen, we've been vaccinated against this for years, so this goes back to 1960s data. Rubella can cause you a rash and a fever and an illness in kids, but in pregnant women, it can actually cause miscarriage and birth defects as well. So you saw 17 deaths per year. Rotavirus is a childhood diarrhea illness. You'd see 20 deaths per year. And COVID, interestingly, just looking at the 5 to 11 year group alone in a 1 year period, has on average 66 deaths per year. So let's talk a little bit about multi-system inflammatory syndrome in children, or MISC, or some people even call this MISC. So this is rare, but a very serious complication of COVID. There's been 269 cases in a recent report that we got from Public Health Agency of Canada. So they looked at the time period between March 2020 and May 2021. So that's a 14-month period. There were 269 cases reported in that 14-month period. They found that it was most common between the ages of 5 to 11. And this was like things like toxic shock syndrome and Kawasaki disease. It had a lot of similarities to those two things. So MISC or MISC starts about 2 to 6 weeks after a COVID infection, and symptoms can include rash, red eyes, fever, bleeding disorders can happen, so problems clotting the blood, and there's inflammation and damage to the heart, lungs, brain, kidneys, stomach, and eyes. It's very serious. It requires hospital care. About 1 in 3 kids who get this require admission to an ICU. And based on this report, we didn't have deaths from this in Canada, but there are long-term complications. So inflammation in the kidneys can cause long-term kidney damage, which might require a kidney transplant, for example, or long-term dialysis. So there can be long-term consequences with some of these things. Another consideration in kids is long COVID. So we've started talking about this a bit more, I found, in the last maybe 6 months or so. So the long COVID is when the symptoms of COVID continue after the infection resolves. So right now, the evidence for children, particularly in this age, is that around 1 to 4% of kids will still have symptoms 2 to 3 months after a COVID infection. And the most common symptoms that they're attributing to long COVID are fatigue, and it can be fatigue that's bad enough that the kids find it difficult to go back to school or participate in any sports. Shortness of breath can come in there as well. Persistent headaches, loss of smell that doesn't necessarily return, sore throat, or difficulty concentrating. So a brain fog, some people will describe that as a brain fog. This can occur after an asymptomatic or a symptomatic infection. So kids can have a very mild infection, and then this can be going on, several months after that. So the goal with vaccination is to lower the risk of infection. So you lower the risk of things like long COVID and MISC. And hopefully, if vaccines work well, they also can lower the risk of long COVID and MISC as well. And I thought this was a nice graphic just to highlight, COVID has a lot of impacts in the body. So COVID enters our cells through a receptor called the angiotensin converting enzyme receptor, the ACE receptor. And we use this, some of you might be on blood pressure pills called ACE inhibitors. This is actually something we know a lot about. We were quite familiar with before the pandemic. And the thing about these ACE receptors is they're all over the body. So they're in the heart, the brain, the spleen, the liver, the blood vessels, the stomach, kidneys, pancreas, lungs. And that's why when you sometimes see with COVID isn't just a cold, right? COVID can have really significant impacts when it's severe on many body systems. So it can affect the bleeding, and it can lead to blood clots. It can cause some pretty significant myocarditis. It can cause problems with the liver. Interestingly, one of the things that it can do is there are ACE receptors in the testicles, and it can at least temporarily decrease sperm count. So we've got ACE receptors throughout the body, and COVID can have impacts on many of these things. So what are the benefits of vaccinating children then? Well, one of them is to lower the risk of illness. And again, most kids are going to have a mild infection, and they may even be symptomatic, but not all kids. So the goal with the vaccination is to protect those kids who would have otherwise had a more severe reaction to the virus. It's also to lower the risk of complications like MISC and long COVID. It's to lower the risk of spread to friends and family. We don't just vaccinate kids to protect other people. We really do it to protect the kids themselves. But an added benefit is that we can also protect maybe a grandparent who's going through cancer treatment, or a classmate or a friend or someone in the family who might have difficulty having a good immune response. It's also so that when there's a case in the class, vaccinated kids don't necessarily need to isolate if they've been a close contact of somebody who had COVID. So some of you might have kids who are at home right now. We've got cases in multiple schools, and there's multiple kids who have to be at home for 10 days isolating and getting COVID tests. When you're vaccinated, sometimes we can avoid that, which is nice. A lot of kids have gone back to their activities like hockey and swimming and dance class and Girl Guides and all sorts of things like that. So one goal too with vaccination is, as the kids are returning to these activities, there's lower risk of infection. And we also really need to remember that not all kids are back at all of these things. There are a lot of kids who do have serious health conditions and kids with disabilities, and they haven't been able to return to school on the advice of their doctors. They haven't been able to be safe in these environments. So it's really about getting all kids back to being normal again. So let's look at the vaccine trial data. So in terms of the COVID vaccine for 5 to 11-year-olds specifically, so it's the Pfizer-BioNTech COVID-19 vaccine that's been authorized by Health Canada for kids who are 5 to 11 as a 2-dose regimen of 10 micrograms given 3 weeks or 21 days apart. That's what was approved because that's what Pfizer asked to be approved in terms of what was used in the trial. So this is a dose that's a third of the dose of the adult dose. Adults and teens get a 30 microgram dose. Kids get a 10 microgram dose. And what they actually studied in the first kids trial, they studied 10 microgram doses, 20 microgram doses, and 30 microgram doses. And what they found was all 3 doses had good antibody responses, but you got less side effects in the lower dose. So they used the lower dose in the clinical trials, and that's why kids have a lower dose that was approved. Now, NACI recommended that we separate those doses by at least 8 weeks because we've learned that in adults and teens, you have a much better and longer protection, duration of protection, when you have dose 1 and 2 further apart than close together. And this is actually true of vaccines in general. The problem with vaccines is often when they're too close together, not when they're too far apart. So NACI advised that we separate them, and also because further apart might reduce the risk of myocarditis if there is a risk of myocarditis. So the study was a randomized placebo-controlled trial. It was a phase 2-3 study. There were 4,500 kids that were enrolled between the ages of 5 to 11. There were 3,000 who were given the vaccine and 1,500 that were given placebo or a saltwater vaccine. This ran from March until October of this year. And this is notable because this is when Delta was circulating. So the kids trial was actually studying COVID and the Delta variant specifically. The kids were given 2 doses of 10 micrograms each, 3 weeks apart. And what they found was the vaccine effectiveness was 90.7%. So what's important to note is there actually wasn't a lot of COVID in this trial. So the kids who were given the vaccine had less COVID than the kids who were given the saltwater the placebo. But there wasn't a lot of vaccine. So there wasn't a lot of infection in either arm. What they were really looking at in this trial was antibody levels. They wanted to see that if we give all of these kids this 10 microgram dose, does that give us the same antibody levels as teens, 12 to 18, who had a really great response, and adults and older people? And what we saw was that even though kids were given a dose that's about a third of the adult dose, they had a very similar antibody response to all the other populations. And we know from the adult trials that that level of antibody does protect pretty well against not only COVID infection, but severe illness, hospitalization, and death. Next slide. So one big question that we get a lot of questions about is safety. So in this trial, specifically with these 4,500 kids, the side effects were consistent with vaccines for 12 and older and adults. So it was mild side effects that showed up, 1 or 2 days after the dose. The most common was injection site pain or redness. And actually the one that was more common with kids than older people was a bit of redness at the site. If you have kids who've had other vaccines, you might notice they get a bit of redness at the site, and adults don't always get that. So you might have seen a bit more of that in kids, but generally the other side effects like fatigue, headache, body aches, diarrhea, mild fever, those were similar or even lower than what we saw in teens and adults. There were no new side effects seen, and there were no severe side effects that were seen in this trial. Next slide. There were also no cases of myocarditis, which is inflammation of the heart, or pericarditis, which is inflammation of the lining around the heart. So this was looked at 3 months after dose 2, and this was a small study. So we do have multiple long-term ongoing 5-year studies planned. What we're really looking at with those 5-year studies is how long these vaccines work for and whether we need boosters and whatnot, but they're also going to be looking at safety as well. Now with vaccines, we expect side effects to show up within about 6 weeks of the vaccine, even rare but serious side effects, things like myocarditis, but Guillain-Barré. With the AstraZeneca vaccine, when we saw the blood clotting disorder, the VIT, vaccine-induced thrombotic thrombocytopenia, those all showed up within that 6-week period. It took a little bit of time to identify them, but they all showed up within that 6-week period. We don't expect long-term side effects to show up, but we watch for them anyway. There's a lower rate of myocarditis expected in the kids 5 to 11 compared to the 12 to 26-year-olds, specifically because it's a lower vaccine dose, a longer interval, and a lower risk age group. And I'll talk about what I mean by that in a minute here. Next slide. So once Health Canada approved the vaccine, the NACI, the National Advisory Committee on Immunization, released its statement on how they recommend that we use the vaccine. So they're our guidance group. They don't set the policies, but they tell the provinces what they think the policies should be. So these are experts in vaccines, viruses, immunology, pediatrics, etc. So they recommended that we have dose 1 and 2 at least 8 weeks apart, because that should give us better protection, so more immunity and longer duration of immunity, and it may lower the risk of myocarditis, because we saw the longer interval and the teens lowered the risk of myocarditis. Here are some of the questions that they anticipated were going to be common, and we certainly do get them, and here's the advice they gave in that recommendation. For 11-year-olds who get a kid's dose, so the 10 microgram dose, for the first dose and then turn 12 and are due for dose 2, one of the questions they were anticipating is, should the child get a second dose of the kid's dose, or should their second dose be the teen and adult dose of 30 micrograms? So what they advise is, if you have an 11-year-old who gets a 10 microgram kid's dose and then turns 12, for dose 2, they can get the teen or adult 30 microgram dose. But if parents prefer that their kid have a second dose, that's the pediatric dose, that's okay too. So in essence, that's really a parent's choice. The default would be to give, once they're 12, to give them the vaccine for 12 and older. But if parents feel strongly that they want their kids to have 2 10 microgram doses, that's okay too. 2 doses may be offered to kids who have had COVID. So they didn't take a strong position on this, but they said, if your kid has had COVID in the past, we know from adult data that you do tend to build a bit stronger immunity if you have at least 1 vaccine dose on top of that natural immunity that you got from the virus. So, and we don't know, but we think, 2 doses would probably offer even longer and stronger protection, especially in light of things like the variants coming out. So for parents who have children who have had COVID, they can be offered 2 vaccine doses if that's what they'd like. Kids who have had MIS-C should delay until they're recovered from that, or at least 90 days after they were diagnosed with MIS-C. And the vaccine should be given at least 14 days apart from other vaccines. This is coming up most commonly right now with flu shots. What this recommendation is, it's okay to give 2 vaccines together at the same time. There's no safety concerns about that. The problem is when you give 2 vaccines together and you get side effects, you don't know which vaccine caused the side effects. So what NACI said is, as we're still learning about these vaccines, we're watching closely on things like rare but serious side effects. If you're going to have 2 vaccines, it would be nice if you'd separate them by 14 days. So if there's a side effect, maybe a red arm, you know what it's from. You know it's from the COVID vaccine, or you know it's from the flu vaccine. The Canadian Pediatric Society, though, actually came out after that and said, but you know what, vaccines can be stressful for kids if kids are afraid of needles. If it's better for the kids, it's better for the parents to give it closer together. Maybe it's hard to get time off work. Maybe it's easier to go and get them at once. Maybe it's less stressful for the child to get 2 vaccines at once rather than 2 vaccines on 2 separate visits. That's okay too. So this is just trying to get the data to be clean. It's not that it has anything to do with the safety for the child. It's really the parent's preference. So if we dig a little bit more into myocarditis and pericarditis, it's important to note that myocarditis and pericarditis can actually happen with viral infections. So COVID can absolutely cause it. The flu can cause it. Common colds can cause it. And it tends to be more serious when it's caused by a virus. So when you get myocarditis from a virus, there tends to be longer time spent in the hospital, longer time to recovery. You're 6 times more likely to get myocarditis with a COVID infection than vaccination. It's most common after dose 2 in young males, especially between the ages of 12 to 26. And there's some thoughts that it might be tied to levels of testosterone, which is why we're seeing it more in young males than young females. It also seems to peak at around age 16 to 17, which is when boys are going through puberty. So it decreases, it's less common in, say, 12 to 14-year-olds compared to the 16 to 17-year-olds. It's expected to be even less common in the 5 to 11-year-olds as well. It is more common with Moderna, and that's actually the reason why you don't see Moderna really used in people under the age of 26. Moderna used a higher dose. So the Pfizer adult dose is 30 micrograms, and the Moderna dose is 100 micrograms. So when it was approved and when it was used for a short period in teens, they did see more myocarditis. It was still rare, but they saw more of it. Myocarditis, when it's caused by the vaccine, tends to be fairly short term. So kids are admitted to hospital often for observation, just as a precaution. We treat it with rest. and non-steroidal anti-inflammatory drugs, ibuprofen, for example, and it does tend to resolve much more quickly than a myocarditis that's caused by a virus. So Moderna has released information on its vaccine for kids for 6 to 12. They have only released a press release, so this is, we really always are a bit concerned about this idea of science by press release. Pfizer did this initially with its vaccine as well. And so we really don't know until we see the data. All we do know is that Moderna looked at 6 to 12-year-olds. They looked at a 2-dose regimen as well. It was a 50 microgram dose that would be 28 days apart, seemed to have a strong immune response that's evidenced by good antibody levels similar to young adults. It seemed to be well tolerated. The side effects were mild, but it's not approved yet. So we'll wait to see what happens with that. So I'm going to go through 4 points on a decision aid that we've created, and I'll show you them all together after, but I'm going to go through them one by one. So some reasons that people may choose to vaccinate a child now are because it could lower risk of serious illness and death from COVID, lower risk of complications from infection like MIS-C or long COVID. You may be able to continue to go to school and do activities after COVID exposure, lower risk of spreading COVID to others, able to safely return to sports and clubs and sleepovers sooner, and able to travel without quarantine. But some parents and guardians choose to wait. And so some of the reasons that they choose to wait are mild side effects that might temporarily interrupt plans. So talking to colleagues, some of them had a hockey tournament coming up, for example, and decided to wait to get their kid vaccinated until after the hockey tournament, or they wait for the weekend, or they wait until the parent has a week off, just anticipating side effects. They're mild. We don't really expect much side effects, but the parents want to wait for some downtime for the kids, for example. That's one reason they wait. Some people wait because of the unclear risk of very rare vaccine side effects when they're waiting to find out about myocarditis, for example. And as I mentioned, we really should have some information about that in the next couple of weeks as the US goes through the millions of doses that it's giving right now. Children living in areas with very low numbers of COVID-19 infections have a lower chance of being exposed at this time. So if you're in Nova Scotia, where there's very little virus, you might decide to wait a bit because you feel that the risks are really slim to none. But if you're somewhere like here, where we have rising rates and we're seeing more class outbreaks, et cetera, or more exposures in the classroom, you might choose to get it done a bit earlier, for example. So choosing to wait can be a short-term plan, and a lot of parents have done that. So if you're doing that, just make sure you're following public health advice to lower the risk while you decide. So what do we know about the COVID-19 infections? Well, COVID-19 is very contagious. The Omicron variant of concern appears to be even more so. Most children are expected to be exposed to COVID-19 within a year. Most children with COVID-19 infections will have mild illness. Some children, including children with no health conditions, can get very sick and can even die from COVID. It's not common, but it can happen. Children can get long COVID and have health problems that last weeks to months. And because we're still learning about COVID, we actually don't know how long these conditions last, if there's long-term or permanent problems after an infection. So we're still learning about COVID too. We're waiting for long-term research on COVID. Myocarditis, or inflammation of the heart, is much more common and severe after a COVID-19 infection than after a vaccine. And COVID-19 can cause MultiSystem inflammatory syndrome in children, or MISC, or MISC, and it's most common in children 5 to 11. So what do we know about the COVID-19 mRNA vaccines? Well, the vaccines protect children from getting sick with COVID-19 and lower the risk of spreading COVID-19. Data from teens and adults shows that health risks is much higher with a COVID-19 infection than vaccination. Vaccines for children aged 5 to 11 use a lower dose than vaccines for teens and adults. There's mild side effects like a sore arm or tiredness, and these are common after the vaccine. They usually go away after a few days. Long-term side effects are not expected. We're still watching for them, even if we don't expect them. Vaccine ingredients are gone from the body in 2 to 3 days. These vaccines do not affect fertility, genes, DNA, or hormones. And myocarditis from the vaccine is rare. It's expected to be even rarer in kids 5 to 11. So this was a decision aid, now or wait, that we have on the University of Waterloo School of Pharmacy page. We're in the process of translating it to other languages as well. So if this is something that helps you, you might be making the decision to get the vaccine right now, or you might be making the decision to wait. The goal of a tool like this is just to help you feel comfortable or more confident in the decision that you're making. So when we were creating that tool, we were testing it out with a number of people. And we got a lot of feedback, really, really great feedback, even for people who very strongly oppose vaccinations and who asked really thoughtful and really welcome questions. And so we put together a 2-pager because we did hear from a lot of people that they needed a bit more information. They wanted to know where things were coming from. So we also have this tool on the School of Pharmacy website that just goes through a lot of the points that I've already gone through, including the dose and the studies and safety, side effects, long-term, short-term, et cetera, and also some information about things like MISC. For those who need a bit more information on myocarditis and pericarditis, we updated this earlier in November. We used Public Health Ontario data, so we got some help from them getting to see their data before they released it, just to give people some estimates and numbers and to describe what we know about myocarditis and pericarditis, including what the signs and symptoms are, onset, and how you treat it. So if you need more information about that, to feel comfortable or to try and understand this, if this is a new concept for you, you can also find that on our website. So here are some other common questions that I get. So a very, very common one right now is, does the vaccine affect fertility? So no, there's no evidence the vaccine affects fertility or genes. And actually, this is a very common thing that comes up with every single vaccination. So it's a very useful thing to say to people to scare them. Oh, it's going to affect fertility, because that's something that's so far in the future that it just gives a little bit of uncertainty. But they have actually studied this with other vaccines, especially vaccines like the HPV vaccine, which we tend to give to teenagers, right? My own daughter just got her HPV vaccine and she's 12. And so there's no evidence that these vaccines affect fertility or genes. There is evidence, though, that the virus may affect, say, sperm count in males. It can actually affect some, the virus can cause some erectile dysfunction, at least temporarily as well. We also know that the virus can be quite dangerous in pregnancy. And we, all of the groups, the Society of Obstetrics and Gynecologists of Canada, the Canadian Fertility and Andrology Society, several groups like this all recommend vaccination for people who are planning to become pregnant or trying to become pregnant. There's also been some research. So for example, they did a study with people who are going through in vitro fertilization or IVF. And what they found is that when people were vaccinated, it had no impact on eggs or hormones, for example. So they are actually studying this, and there is really no evidence that these vaccines affect fertility. People in the clinical trials for the vaccines were also, they got pregnant in similar numbers. They were not supposed to get pregnant in the trials, but they did, because things happen, and it happened in similar numbers, both in the intervention arm, the vaccine arm, and the placebo arm. Does the vaccine affect menstrual periods? So maybe. Both COVID infection and the vaccine might cause small changes in menstrual periods for 1 to 2 cycles. So people might find after their COVID vaccination, or if they get a COVID infection, they might have a lighter period or a heavier period or a longer period. That might happen for 1 or 2 periods, and then it should go back to normal. This actually happens with other things. This happens with other vaccines and other viral infections. And actually stress also does this as well. So periods can be very susceptible to all sorts of things, your immune system, changes in your immune system, or even stress, like I mentioned. So if my child had a COVID-19 infection, should they still get the vaccine? So as I mentioned, NACI advises that people with natural immunity still get the vaccine. Research on adults shows that even 1 dose of the vaccine after infection leads to much higher antibody levels. And my child is big for their age. So you might have an 11-year-old who's as big as a 15-year-old. Should they still get the bigger dose? So no, vaccine doses are not based on weight. They're based on age. Kids, young people, have very, very strong, very effective and efficient immune systems. So we can give them smaller doses, and that's what the study showed us. We can give them smaller doses and they can make as much antibodies as adults. So because they have such strong immune systems. So no, if it's based on age, if you have an 11-year-old who's really big, they can still get the 10 microgram pediatric dose. If you have specific questions, so maybe your kid has a condition, maybe your child has a serious health condition, maybe they've had a reaction to the vaccine in the past, or they're on some medications, for example. If you have a specific question, this is a really wonderful service. So it's sickkids.ca/vaccine consult. I have had friends who have called this, I have friends who, for example, have had children have very serious complications from the COVID virus infection, and they've called the SickKids line and said, okay, this happened after the infection, should I still get the vaccination? What happens at this line is that if they can't answer your question when you call in, they actually go to one of the specialists at SickKids who has experience maybe treating your child's rare condition, for example, or expertise in your child's illness. And they actually get specific information back for you. So very, very useful, very helpful line. So that's an option for you. And I've just got a few last slides here to talk about kids who have fears with needles. So I grew up with a pretty strong fear of needles, and a lot of kids develop this. So you can have kids who are even fine for their 4-year-old vaccine that doesn't bother them. All of a sudden, at 10 years old, they develop a fear at 15 years old. So this was a strategy that was developed with a colleague of mine developed this at the University of Toronto, and they worked on this with folks at SickKids, for example. And it's called the CARD system, C-A-R-D. And the way they set this up is these are cards that the kids can choose to play. And you can say to the kids, which card do you want to play? So the cards are the comfort card, the ask card, the relax card, and the distract card. So for example, if kids want to do some things to increase their comfort, they can make sure that they eat beforehand. So we don't want hangry kids, right? Hangry kids can be upset kids. Hangry is hungry, angry kids. So having a snack beforehand, making sure that they wear a top that makes it easy to reach their arms. So they're not having to, sit topless on a chair as they're trying to get to their arm. Maybe bring an item that brings them comfort, like a stuffed animal or a blanket. Teaching them or helping them learn how to relax their arm, like cooked spaghetti, so it's nice and loose and jiggly. If you've got teens, especially who are prone to fainting when they get nervous, like when they bump their toe, or if they're giving a speech, or even they're getting a vaccination, when they sit squeezing their knees together for 20 seconds so that the blood returns up to their head, that can make a big difference. So that's the comfort card. The ask card is letting kids ask questions before you get in. So what's going to happen? What's it going to feel like? Can I bring someone with me? Can I have privacy? Can I have a numbing patch? Can I lie down? And remember, when kids ask things like, what's it going to feel like? We don't want to lie. We want to be honest, but we also don't want to say words that are going to evoke fear. So we don't want to say, well, it's going to hurt, but it won't hurt for long. We might say it's going to pinch, but it only lasts a second. Or you might feel some pressure, but it's over very, very quickly. So we can be honest, but also set them up for knowing what to expect. An option with the ask one is the numbing creams, which I'm going to talk about in the next slides. So relax, it is the next card. This is getting kids to take slow, deep belly breaths. So this can be bringing bubbles and blowing bubbles through their mask. For example, when it's not a pandemic, this is great for flu shots and kids shots, positive self-talk, having someone there to support you, privacy, sitting on a parent or a guardian's lap. And my favorite is the distract card. So asking the kids to plan ahead of time, what distraction do you want? They can bring a video game, they can play on their parent's phone, they could listen to music or watch a movie with headphones, something that they can think about that actually takes their attention off of what's going on. It can be wonderfully effective. It makes a huge difference. And I will actually say this can make a huge difference with adults as well. So something that I always do with my kids, and I'm surprised more people don't do this, is I always use numbing patches. So in particular, I use the EMLA numbing patch. This is a resource from Alberta Health Services. I really like this one pager. You can Google commitment to comfort or numbing cream Alberta, and this will come up. So you've got 3 kinds of numbing creams here. The one that I usually buy is EMLA because it comes in a patch that's really easy to apply. 2 patches are about $13. I go to the pharmacist, I ask them, they have it behind the counter. You don't need a prescription for it. And you put it on the spot where the child's going to get the vaccine at least an hour ahead of time, and it numbs the skin. So the child doesn't feel the needle going in. They might feel the pressure when the liquid's actually injected into the muscle, but it doesn't hurt. So they'll just feel some pressure, but they don't actually feel the needle. The other ones, Maxilene and Amatop, are nice options if you have a lot of kids. So maybe if they're going with friends or with cousins, or you have more than a couple of kids, these come in a tube and you apply them. So Amatop, you need to apply about 45 minutes before the injection, or Maxilene is about 30 minutes. These are also great for painful procedures, IV, taking blood, things like that. So to put them on, what you do is with the tube of cream, the patch would go on like this, but with the tube of cream, you put on about the amount of like a quarter or a nickel, a 5-cent or a 25-cent coin. Put a dollop of cream on, and then this on the left is a Tegaderm patch, but if you see on the right, or saran wrap, you don't want to rub it in. You actually leave it in the spot and you wrap it up. You let it sit for about, again, 30 minutes, 45 minutes. It numbs the skin. When you take off the bandage or the patch or the saran wrap and you wipe off the cream, sometimes what you'll see there is a bit of a red spot or a blanched spot. It can be a bit pale. And that's actually a good thing because it's a normal side effect with it. But for the vaccinators, it actually helps us see where the skin is numb. And so we make sure that we go in the place where the kid actually had the cream on. So in summary, the risk of COVID-19 infection is likely much greater than the vaccine, even in kids 5 to 11. So most kids who do get COVID-19 in the 5 to 11 group are going to get a mild or asymptomatic COVID infection. And that's normal. I know this is a big talking point with this, but some will have a severe illness or prolonged symptoms. The vaccine has been given to over 4 million kids aged 5 to 11, and real world data is being compiled right now. Real world data will tell us about rare but serious side effects, though none are expected. Long-term data are needed to know how long vaccines will protect us and if we need boosters. And I can say that my children are 12 and 9. So my 12-year-old has had both of her doses. She got them this summer. And I took my 9-year-old in on Saturday. She had her first dose. We put her MLA patch on and she had a bit of a sore arm the next day, but she still managed to go to swim practice and didn't have any problems with that and really didn't seem to have many other side effects. Most of her friends around her also went in for their doses, and they seem to all have pretty straightforward, a bit of a sore arm, bit of redness as well. So all in all, our experience was that we found it to be pretty well tolerated. And I'm sure there's lots of you even on the call who may have taken your kids in and got this as well. So I'll end there. Thank you.
Thank you, Dr. Grindrod. We're now going to hear from Adele, who's going to walk through how to book a vaccine appointment for 5 to 11-year-olds. And then Adele's going to be reviewing your questions with Dr. Grindrod during a Q&A section. So I'll pass it over now to Adele.
Thanks, Jonathan. There are several types of clinics that you can go to have your child immunized. These include mass immunization clinics, school clinics, and clinics at kidsAbility. So how to book vaccine for children age 5 to 11. So please book through the Region of Waterloo website. So this is regionofwaterloo.ca, get a vaccine, and select first, second dose, age 5 to 11 as the priority group. And then complete the form with your child's information. And if you need any extra support, you can call the region's main line, and that's 519-575-4400. And we have support available in over 200 languages. And we also have a phone line for people who are deaf and hard of hearing. This is 519-575-4608. So as I mentioned, there are various locations that your child and clinic types that your child can be immunized at. So first of them are the mass immunization clinics. So we have one at Pine Bush, Cambridge Pine Bush Center in Cambridge, one at 150 Frederick Street, downtown Kitchener, the Wellesley Clinic in Kitchener, and also the Boardwalk in Waterloo. There are also coming up several clinics that are being held at schools. So we have clinics that are after school hours, so running from 4 till 8 p.m. And then full day school vaccination clinics. These are on weekends that are running from 9:15 to 3:15. So the dates and times are there, but I'll just quickly go through. So December 2nd, we're at St. Peter's Catholic Elementary School in Cambridge, the 9th and the 14th at Wilson Avenue Public School, the 15th and the 16th at Sunnyside Public School in Kitchener. And those are the 4 to 8 p.m. clinics. The full day clinics on December 4th, we're at Queensmount Public School. December 19th and 20th, we're at St. Bernadette Catholic School in Kitchener. December 21st and 22nd, we're at St. Anne Catholic School. That's the one in Cambridge. And then on December 23rd, we're at Linwood Public School. And lastly, there's also the option of attending the clinic at kidsAbility. So there are 2 locations for kidsAbility, one in Kitchener and one in Waterloo. So these clinics are sensory-friendly vaccination clinics for children between 5 to 17 years of age. And these are for children who would have difficulty getting the vaccine at a regional vaccination clinic. So it's excellent for families accessing kidsAbility services, as the children may see some friendly faces. So how to book at kidsAbility? So anyone who feels their child requires the additional support of a sensory-friendly vaccination clinic is encouraged to contact the Region of Waterloo for a referral form. And so you can receive this form by emailing publichealth@regionofwaterloo.ca or calling 519-575-4400 and just ask for a referral form for kidsAbility. So just to summarize there are 3 locations and types of clinics. So there's the mass immunization clinics, there's the clinics that we're hosting in schools, and there's the 2 clinics at kidsAbility. So we also received some questions before tonight about what to bring on the day of the appointment. And so I'm going to answer those ones. So on the day of your appointment, please bring your child's health card and a list of any medications your child may be currently taking. And parents will be given a receipt with information about the vaccine they received. And just keep this vaccination in a safe place. And if you provide your email or text number, then that will also provide you with the information that way. Next question is, do you need a health card to receive the vaccine? And the answer to that is no. So if you have a health card, we're asking you to bring it with you. But if you don't have a health card, the vaccine staff at the staff at the clinic will be able to assist you. Does my child require consent before receiving the vaccine? So we are asking that a parent or a guardian accompany their child to the appointment. Under the Healthcare Consent Act, there is no minimum age of giving consent. So the capability of giving consent will be assessed at the clinic, and you will be asked to provide consent if your child is not able to do so for themselves. So informed consent means that you understand what the vaccine involves, why it is recommended, and the risks and benefits of getting it or not getting it. And all of that will be provided to you by the nurses who are administering the vaccine. And they will ask specifically for your consent. Okay, so we were also asked if there were specific clinics for people who are First Nations, Métis, and Inuit. And there are 3 different clinics upcoming. So one is at the Southwest Ontario Aboriginal Health Access Centre, and the phone number there is 519-514-1499. There's the Anishinaabe Outreach COVID Vaccination Clinic, and that's 519-208-5333. And then the Healing of the 7 Generations and the Kitchener-Waterloo Urban Native Wigwam Project are also hosting vaccine clinics. And you can phone them at 519-570-9118. And they'll be able to tell you the dates and times of those clinics. Some of you know this already, that I've been busy cataloging all of your questions. So, Dr. Grindrod, there are a lot of them, and some of them you have answered during your presentation, but I will potentially still ask them since people have asked the question specifically. So the first question is, how long will the immunity last after both doses of the vaccine?
So that depends on who you're talking about. So I think what we've learned is if we're in the older age groups, so definitely the 70 and older, very possibly the 50 and older, maybe even younger. After that second dose, you get really amazing, that sterilizing immunity a couple of weeks after, and it really drops about the next 4 months. So you still have good protection, but it's dropping from like 90% protection down to maybe 50%, 60% protection. But in that, you're still maintaining, from what we can see, we still, from real world data, seem to be holding on to almost 90% protection against severe illness, hospitalization, and death. So when we're talking about waning immunity, it's really important to note that what we're talking about is being protected from getting a symptomatic COVID infection, not necessarily even that severe illness, hospitalization, and death. What we don't know is when you're getting into these really wonderful immune systems of kids, right? Like teens, the 12 to 16-year-olds, young adults, so 16 to let's say 26-year-olds or 18 to 26-year-olds. And then these 5 to 11s, they have such wonderful immune systems that they may hold on to that immunity a lot better. And that's one of those long-term study questions that we need. So we know right now that adults, like for at least for 50 and older, possibly, even like 18 and older, that this is probably a 3-dose vaccine. We always have that question. There's an awful lot of 3-dose vaccines. Hepatitis is 3-dose vaccines. The polio vaccines, multiple doses. Measles, mumps, rubella have multiple doses. So that's not really a surprise that it's a 3-dose vaccine. The question now for people, say 70 and older, 50 and older, 18 and older, is if they get a 3rd dose, how long does that 3rd dose work? Is it a 3-dose vaccine that's good for years? Is it a 3-dose vaccine with some boosters just for the variants, as we still got a lot of the world being unvaccinated. There's a lot of unknowns there. And so I think it's probably, in answering that question, we're tired of uncertainty. I think a lot of people are really tired of unknowns and uncertainty. But what we do know is that after 2 doses, especially in older people, immunity wanes about 4 months, 6 months after that second dose. We don't know if that immunity wanes in the same way in teens, and we won't know for some time yet if it's going to wane in children.
Thank you, Dr. Grindrod. So that is another question. Your answer here also included another question that people have asked is, you say that children have such great immune systems. So if that's the case, why are we having them vaccinated?
Yeah, it's, when we having good immune systems, like with COVID, the severe COVID infection, often the severe outcomes are your immune system taking it a little bit too far, right? So COVID infections can cause all sorts of things in our body. Most kids have mild symptoms. Most kids, a lot of kids have asymptomatic infections and they get some immunity, but not all kids. And the hard part is you can't predict which kids are going to have that severe infection. And we have to be really careful, because I think in the pandemic, it was so bad when it got into long-term care homes, and it had, 1 in 3 death rates, 1 in 2 death rates, and it, whipped through long-term care homes. It affected PSWs, healthcare workers were impacted. It was overwhelming. It was so bad. And we were grateful it wasn't that bad in children, but that was extraordinarily bad. And when we actually look at kids, and we have to take a step back and we have to say, not compared to seniors in long-term care homes, because luckily children don't get nearly as sick as seniors in long-term care home. Thank goodness that didn't happen. But compared to other preventable illnesses and childhood illnesses like chickenpox, like rubella, like some of these other conditions, COVID's actually worse than a lot of them. And so, in the US, having 500 children die, in Canada, we've had 20. It is possible to have healthy children get a severe infection and die from this, and to have some permanent problems such as kidney damage and others. So many kids could get good immunity probably from an infection, but there's a lot of risk in that, because we don't know which kids are going to get that severe illness. And generally speaking, with other conditions, we haven't been comfortable with that. And so it's been really hard to risk assess with COVID, I think, with kids in particular, because we're often comparing them to seniors, which was a completely different group, not with other childhood illnesses. And even compared to other vaccine preventable illnesses in children, polio, things like that, we can still have some pretty severe outcomes with COVID.
So another question, and there's a few that I pulled together here, around the long-term safety effects. And so this is a fairly new vaccine. And so people are asking, why don't we wait until we know the results of some of those long-term studies?
Well, one of the hardest parts about living in a pandemic is it doesn't give you the luxury of time. And so you're not waiting for a vaccine in a risk-free environment. What we expect, especially as more contagious variants emerge, Delta was so much more contagious than the Alpha variant, which was more contagious than the original, what we call wild type variant. And Omicron, and it depends on how you want to pronounce it. Also, there's a question, there's some early data emerging suggesting it may be even more contagious than Delta. It's a bit too early. We don't quite know yet. But if that keeps happening, for example, we really do expect that most kids are going to be exposed and possibly infected, say through school and activity and whatnot in the next year. So it's not necessarily a choice of my kid, waiting to get the vaccine until I know it's safe. They're not going to get COVID or anything like that. That's not the world that we're in. Quite likely by waiting in that time, they have that consistent risk of getting COVID as you wait. And I had a colleague whose 2-year-old recently got COVID just in the last couple of weeks. And one of the things he said, parents were both fully vaccinated. He said, the child had a fever for over a week, was really lethargic. He was really quite sick. And he said, I was really surprised in a child that young, how sick it was. It's their only child so far. He said, that was so stressful watching my child be that sick for that long. And even the fully vaccinated parents were actually quite sick. He said, I was a lot sicker than I expected. So when we talk about a moderate COVID infection, that's actually pretty sick. Severe means you're sick enough you need to go to hospital. When we say moderate, it doesn't mean a bad cold. It means it's hard to get up off the couch. You might have difficulty breathing. You have a significant cough, fatigue for weeks after. That's still a moderate infection. So I sometimes, especially if we haven't had people around us have a COVID infection, including kids, We don't always have a sense too of what it can look like when kids, and even what that might have been considered a mild infection in my colleague's child, but it was very stressful for the parents, and it was a fever for a week and they couldn't go anywhere and everybody was sick. So, it is important to acknowledge that we don't have long-term data on COVID either. Viruses, there are many, many viruses that stick around in our body and have long-term effects. And one of the best examples is hepatitis. So hepatitis A and B. Hepatitis B in particular is actually over long-term is tied to liver cancer. HPV, which we vaccinate against in grade 7, is tied to multiple cancers of the reproductive tract, anal cancers, throat cancers. We have, herpes infection. You get a cold sore, that's a herpes virus. You have herpes cold sores for the rest of your life that come and go. And actually, if you're immunocompromised, you might get this when you're young, maybe in your teens or as a child or in your 20s. When much later in life, when you're going through cancer therapy or you go through an organ transplant, that can come raging back as a herpes meningitis. So, once we're infected with a virus, I think the other best example is chickenpox virus. In childhood, you can get chickenpox. Well, that comes back as shingles as an adult. Shingles is actually your chickenpox virus from when you were a kid coming back later on in life. So many, many viruses have long-term effects. And I really caution people at this is not just a cold or a flu. This is a novel virus that we don't know much about. And we really need to consider that we also don't know the long-term effects or implication of getting infected with the virus.
So there's a few questions about vaccine safety, and some of them are asking about the fact that it was approved under emergency use. And how is that different than the normal process that vaccines would go through before they're used?
So in Canada, this had to do more with bureaucracy and making the process more efficient and organizing people to be able to review more quickly. So what emergency use or emergency authorization in Canada meant was that all the same steps were followed, all the same material was required to be submitted, all the same trials. And actually with this vaccine, these were massive trials that were done in adults. And actually these trials, we often hear that these pediatric trials were small. These are enormous trials for kids and kids vaccines. We don't normally even get trials this big, that the 4,500 that we saw with the kids with this. So what they had to do was, by allowing it under this emergency authorization process, the companies that were studying these were allowed to submit data early so that the reviewers at Health Canada could start looking at the data well before the final submission. So and they were doing this, like they were on 24-hour schedules. People were scheduled to come in all day long and review, and different teams came in and reviewed all night long. What they do in these is they submit huge reams of paper and data. And I mean, they're looking at every single child, every single adult, every single person in the trial. They're looking at all the outcomes. They're looking for anything that was missed. All of that happened. So under the emergency use, when the final application was submitted, most of the data had already been submitted and reviewed. That's not how it works in the normal time. In normal time, you submit it, and then from the point you submit it, everything starts being reviewed, and it is slow and it takes months and sometimes it takes years. So all this meant was it was the exact same processes that were followed. They were just much better organized and much faster, and everything else got pushed to the side for them to focus on this.
So there's a couple questions here about getting the COVID vaccine at the same time as the flu vaccine, but there's also the question about what if a child is behind in their immunization schools, Pupils Act vaccines. So kind of a double question there about what if they're behind in their vaccines, and can they get the COVID vaccine at the same time as the flu vaccine?
Yeah, you bet. And so that was the big concern when NACI had the statement, which is about a week ago now, and they said we would prefer that COVID vaccines be separated from other vaccines by 14 days. A lot of people, including pediatricians, pushed back on that and said, are you sure about that? Because there's a lot of kids who are behind on their vaccinations. We've got flu shots going on right now. And what I'm hearing from pharmacists is the number one question people are calling with is, I had my kids scheduled for a flu shot. Do I cancel it? And do I come in for the COVID shot? So that's why what you're seeing is the advice is, if it's, it's all the same to you, we'd appreciate it if you'd separate it by 14 days. But if that's going to cause any sort of problems for you, including transportation, difficulty getting to the clinic. If it's a lot easier and it's much preferred for you to get them at the same time. So even other vaccines that the kids need to get caught up on, it's okay to give the COVID shot at the same time as those other ones. So maybe you need to go in and see your doctor and catch up on some of these other ones. They could give you the COVID shot at the same time, or you could wait 2 weeks. Now, what you might want to do is if you are going to separate them, COVID is probably the bigger risk right now compared to the other things. So for example, we're not seeing a lot of flu yet this year. The masking and the good ventilation and the staying home when we're sick and the washing our hands seems to be keeping those flu numbers down. So if you're going to make a choice, you probably want to choose the COVID vaccine first and then do the flu shot, say 2 weeks later. Same with if you're going to do it, go get the COVID shot, say now, and then a couple of weeks, go see your doctor and get caught up on some of those kids vaccines. A lot of kids are behind right now on their vaccinations because people haven't been going in and seeing their doctors who do the bulk of those, right? So it's really up to you. If it's possible, separate them by 2 weeks. That's what's preferred, just to have good, clean data. But everybody's life is different. If you want to have them together, it's okay to have them together too.
A question here about, do people have to wait the 8 weeks in between doses? People are talking about, we're traveling for Christmas, and can we have it done less than 8 weeks apart?
This was also the big question for NACI when they said this. A lot of people said, but they're gathering at Christmas, and how much better is it at 8 weeks? So the monograph says 21 days. And the policies, like in the province, you might find that pharmacies are somewhat restrictive, that the pharmacies can't give it at 21 days because the government has given them very clear instructions at 8 weeks. But for example, at one of the public health clinics, when you're calling to book, you could call ahead of time. And physicians can do this because based on the monograph, they can give it based on what's approved by Health Canada, which is 21 days, even though what's advised is 8 weeks. So yeah, you may prefer. So this summer, for example, when I was getting my 12-year-old vaccinated, I wanted to make sure that she had both doses before she returned to school. So I had her 2 doses. I think they were maybe 24, 25 days apart. And what was recommended at the time was say 28 days. And so, but I could do as early as 21 days. So I was making that choice as well. Is it better for me to delay that second dose, or is it better for me to send her back with slightly better immunity earlier, maybe at the expense of slightly less good immunity in the longer run? I can tell you, as someone who reads an awful lot about this, most of my day I go to bed reading articles about this stuff. I wake up in the morning reading articles. I didn't know how to make that decision. So I think if you feel like you want your kids to be fully vaccinated before you go on a trip or get together at Christmas, you can certainly talk to the vaccine clinic about that for it to be an option for you. Pharmacies might have their hands tied a bit, but you might have more flexibility with the vaccine clinic or with your family doctor.
In the news is a lot about boosters and how we may need boosters every year, especially against the variants of concern. So what protection does the Pfizer vaccine provide to children and youth against the variants of concern?
Yeah, and I didn't include much about boosters because the truth is we don't know anything about Omicron right now. There's a lot of people who are kind of saying things about it, but the truth is for another probably 2 weeks, we're not going to know much at all. We're not going to know how effective the vaccines are. Early signs suggest the vaccines are actually pretty good for Omicron, but we won't know for a couple of weeks. Early signs suggest it is more contagious, but we won't know for a couple of weeks. Because we probably do have some waning immunity in those older populations, so 50 and older who maybe had their last dose about 6 months ago. It's prudent to give that third dose because it is increasingly looking like this is at least a 3-dose vaccine, much like the hepatitis B vaccine, right? This is no different than other vaccines that we've got. So that's why we saw announced today in the province, 50 and older are now becoming eligible. But what's interesting to note about that is the 50 and older group, many are actually not eligible right now, but they will become eligible 6 weeks after their second dose. So that might mean you have to do the math and it's kind of hard. Vaccine Tracker Canada has they have a calculator that you can look at. It's on the Waterloo region website to figure out what 168 days is for you. But a lot of those folks aren't even coming due until mid-December, late December into January. We probably are going to see an announcement soon, maybe not at a provincial level, maybe a push towards 18 and older becoming eligible for that third dose as well. Again, those people who, a lot of them got their second dose in July or August, so they're not due well into 2022. It's really way too early. I think the 12 to 16-year-olds and the 5 to 11s are a completely different group because they have those youthful immune systems. So we really truly don't know. The one thing I want to flag, though, that you said there is getting boosters every year. We have no idea. And I think anybody who says anything with any degree of certainty right now, I really would question that. So we don't know if it's going to be annual boosters. It might be in response to variants, but so far the vaccines have been actually holding up pretty well with the variants. So, it could be we have another booster in a couple of years. It could be a 5-year booster. It could be for a little bit. We end up with like a flu COVID combined shot. We know that. I think Moderna is studying that. Novavax is studying that as well. Some other people. So we don't know what to expect. And that's the unfortunate uncertainty we kind of live with in this pandemic. We don't know what's going to happen with vaccines, 2, 4, 10 years in the future.
So Dr. Grindrod, I'm going to ask you a question myself. So it is 8:26, and we had decided that we would end this at 8:30. So are you willing to stay for an extra 15 minutes? We probably have an extra 15 minutes worth of questions here.
Sure,
Is that
no problem.
okay? Okay. Let me see where I am. I know you answered this question earlier, but it has come up a lot. So is there a risk for a female child who gets their vaccine now? Is there a risk for her reproductive health, and specifically about stillbirths?
Yeah, so this is a good question that comes up again and again and again. And I think what I'd mentioned too is that this comes up with every vaccine again and again and again. There's no evidence to support that people who are vaccinated are any more likely to have miscarriage or stillbirth. So there's no evidence that. And actually, we had a lot of people who were vaccinated in pregnancy. And now the vaccines have been around long enough, and in the trials as well, they were vaccinated, have then gotten pregnant, and then had children. And there's no evidence that the vaccine, one way or the other, has any impact on that. COVID is a risk for that, though. So a COVID infection can be very dangerous in pregnancy, including stillbirth, miscarriage. Stillbirth, I assume when it says stillbirth is not just miscarriage, but later term miscarriage, right? So COVID certainly can be a major risk to both the person who's pregnant. We see a much higher risk of being admitted to ICU. And that's actually because your immune system is in a different place when you're pregnant. It operates differently. So when you get a COVID infection, your immune system really takes it way too far in a pregnant person and kind of goes into overdrive. And that actually can cause a lot of the damage. How we actually treat COVID and someone who's pregnant is delivering the baby, interestingly, because by the person not being pregnant anymore, that can actually be largely what saves their life. So we have to be very careful with that. And so vaccinating children, I think this question is, if I have a daughter, for example, will vaccinating her now increase the likelihood of stillbirth in the future? And it's such a hard, I think this is why we see this come up again and again in the anti-vaccine rhetoric, is that it's such a vague fear that it's so effective to say this to people, and then it becomes a doubt that just sits in the back of their mind. And that's actually how I see it worded in the anti-vaccine literature online is people will say, well, how will you know? Wouldn't you feel terrible if this happened in the future and you had no idea? And I think you have to be very careful watching out for that, because that comes up with almost every single vaccine. It is studied with other vaccines. There's no evidence whatsoever that's the case. And that, one interesting study that was done in rats that I was looking at the other day, they took rats and they gave them human doses of the mRNA vaccine. They gave them 2 doses. Now, if you think in rats, they're tiny and humans are big. This was like 300 times the dose you would normally give a rat if you were based on weight. So they gave them human-sized doses to these small rats. They gave them 2 or placebo, 2 doses of 30 or placebo, and then they impregnated them. There was no difference in the rate of getting pregnant. And then during the rat's pregnancy, they gave 2 more huge, massive doses and it had no impact. And so there's lots of ways that they're looking at this. Another one that they've looked at is, I think I mentioned this, an IVF study, in vitro fertilization, where they had women and people going through in vitro, and who were vaccinated, unvaccinated, they looked at the eggs and they looked at the hormone levels. And they didn't see any differences either. And so, because of this actually gets studied an awful lot, because there are a lot of worries about this. There's no evidence that the vaccines have any impact on fertility, on pregnancy, and if anything, they're recommended for people for when the future, when they become pregnant, to protect against that severe illness. And that's by the Canadian Fertility and Andrology Society, Society of Obstetrics and Gynecologists, National Advisory Committee on Immunization. They all advise that people who are planning pregnancy or who will be pregnant in the future get vaccinated now.
So a couple of questions about the vaccine itself. So oftentimes it's said that vaccines are made with a tiny amount of dead or weakened germs. And the person is saying, is that the case for an mRNA?
Right, so they're referring to an inactivated vaccination. So you might grow some virus, for example, in eggs, like with the flu vaccine, and then you deactivate or you kill, formaldehyde is some of the ingredients. Like those old things, the ingredients that people used to not like in other vaccines. That's part of what they were doing sometimes, is creating those inactivated type vaccines. And then what you would be injected with would be kind of a killed version, so not an alive version anymore, of the flu or something like that. And then your body would learn from it. The mRNA vaccines, what made them really interesting, and the viral vector, the AstraZeneca Johnson & Johnson to a certain extent, what made them interesting is what they were doing instead was they were focusing on working with your body to make a small piece of a virus. So not the virus, and you weren't being injected with the virus, but instead your body was being taught to make a small piece of the virus, memorize that piece of the virus, and then get rid of that piece of the virus. And the advantages really there is that the flu vaccine, if you think every year, the thing that's most annoying about the flu vaccine is we never know if it's a good match. You have to you put your orders in way ahead of time. They're trying to look at it. So we're looking at Australia and what's spreading there to try and anticipate what's going to spread here, which influenza A, which influenza B, what's going to be the dominant strain. And we don't always get it right. The nice thing about the mRNA vaccine is you don't need a whole lot of notice. So for example, they're already looking at building an Omicron variant booster if needed. And they've likened it to like having a CD player, and you almost just take out the old CD and you put a new one in, and you can have that slightly different spike protein, for example. So it's a much more adaptable technology. And the nice thing, they've been researching mRNA since the 1960s. The mRNA vaccines themselves they've been looking at, rabies vaccine, I think it was about 2013 was the first time they were looking at an mRNA vaccine in people. So they've been looking at it for quite some time because it held a lot of promise for being very adaptable to new and emerging viruses, but also things that have really we haven't been able to build vaccines against. We've really struggled to make an HIV vaccine. We've really struggled with an effective malaria vaccine. Malaria is a terrible illness, and it's really hard to have an effective malaria vaccine. So that's a lot of the hope here is a much more agile vaccine. And that's how it's different. So the old ones, the killed ones, that's the traditional way of doing it, but they're a lot slower. And there's more involved, and there's more ingredients involved. The mRNA vaccines have much simpler ingredients, so there's very little in them, which is interesting for me as a pharmacist. When I read the ingredient list, it's just sugars and some cholesterol with this mRNA. Plus, it's much easier to adapt to emerging things like a new variant, like Omicron. So it's been a pretty amazing thing to see all those decades of science actually come together kind of in that moment exactly when we needed them.
So speaking of ingredients, so someone asked the question of why was tromethamine added to the children's vaccine?
Yeah, it's a buffer. And so it was interesting because that came up early on. It's a pretty common ingredient. It's just a buffer, and it makes it a little bit more stable. And so what's really nice for those of, for vaccine supply and whatnot, it's stable much longer in the fridge. So one of the challenges with Pfizer when it first came out, and everybody would be aware of this from the news because we all followed this so closely, you have to freeze it at crazy cold temperatures. It's very fragile. It had a very short expiry time once it was thawed in the fridge. And by using a slightly different buffer, a very common ingredient, it's in lots of things, it was nothing new. And there were no real concerns about it because we have lots of experience with it, but it was just more stable. It appears to be a little bit more stable. And so what it's allowed the vaccine to do is to stay at fridge temperatures for longer, which makes it easier to transport. It decreases our chances of having waste, among other things. So yeah, it was a more stable buffer. It wasn't really a huge change. It was just a slight tweak. It doesn't change the effect or even the safety of the vaccination. It really just has to do with stability.
Few more questions here. How are we tracking adverse reactions?
Yeah, there's a couple of ways. So in the trials, that was one way. So everybody had to report on the trials, and there's special groups who are asked to do additional extra tracking and reporting. What we're doing now is if you have an unusual or unexpected side effects, so not the ones we know are going to happen. So most people will have a sore arm. That's typical. We don't report that. People might have redness in their arm. Again, typical. We don't report that. Body aches, fatigue, chills, those kinds of things. Those all came up, and they're common in the trial. The percentages could be 3 out of 10 or 4 to 10 or 6 out of 10. Those are all expected, not serious, expected side effects. So we don't report them. Whenever something is unexpected or serious or unexpected. So for example, if there's redness in the spot, but the redness goes all the way up to the neck and down below the elbow, that's maybe not what we were expecting. So we fill out a form called an AFI form, an adverse event following immunization. And this is a standard form. So if I fill one out, if I see a patient and fill out an AFI form, it gets sent to the Waterloo Region Public Health, who then sends it on to Public Health Ontario, who then sends it on to the Public Health Agency of Canada. And you can actually look at the compilation of these on the Health Canada website. And I do. Someone who talks about this a lot, I check in, and they've compiled the serious, rare but serious side effects. So they're looking for things like Guillain-Barré, which is something that we see with infections and vaccinations, myocarditis. That's where the blood clots were coming in, with the AstraZeneca way back when. That's actually how you discover a lot of those things, is by anything that's not expected coming up. Even if we think, like in the trial, the big joke was that, one of the children swallowed a penny, and that is still reported as a side effect. Like, we even report things, even if we have no idea that it's caused by the vaccine or not. If we're not sure, we fill out an AFI form and it gets sent off. So pharmacists fill this out, family doctors fill this out, people call public health and report a side effect, they'll fill this out. Even things like, when it's injected, if it's injected a bit too high and there's some shoulder mobility issue, we fill out an AFI form. So we're tracking these. They're looked at very closely. And then the next step is when these reports go in, we have to see, and we're watching very closely, things happen in real life. You could be like, you're going to have a heart attack tomorrow. Let's say you're going to have it one way or the other. If you happen to get your vaccine today and you have a heart attack tomorrow, we might think it was because of the vaccine. If you didn't get the heart attack today, didn't get the vaccine today and have the heart attack tomorrow, you would never think it was a vaccine. So one of the things we have to try and figure out is what was the baseline rate of things that were going to happen anyway. So every day, heart attacks, strokes, blood clots, all sorts of things happen. What we're watching very closely is what we call signals. So things that seem to be happening more than usual, Bell's palsy, some of those things like that. We're watching very closely to see if any serious side effects emerge. If they do, even what we call signals, we investigate very closely. We might go out and specifically try to look for them. We look in other databases with linked health databases to see if they show up. So there's a huge amount of work that goes into tracking safety that a lot of the public doesn't always see or even get a chance to participate in. But absolutely, lots of people come in and we'll fill out an AFI form and we'll submit it. Whether we think it's linked or not, if it's following vaccination and not expected, we fill out a form and we submit it.
So 2 more questions, and then I'll pass it back over to Jonathan. You answered this in your presentation, but it did come up quite a bit. If you have a child who is smaller for their age, or a young child, but the weight and height might be of an older child, which dose should they get?
So dose based on age, not based on weight.
Okay.
So if they are a big child or even a small child, and again, the pediatric dose, the 10 micrograms was chosen because in that first dose finding study, which actually went a little bit before the phase 2-3 trial, but it was more like a phase 1 type trial, they did test the 10 20, and 30 microgram doses. So 10 is what was chosen for kids, 30 is what teens and adults get. They tested all three dosage levels. All three dosage levels produced similar levels of antibodies. It's just the 10 microgram dose had slightly lower everyday kind of side effects than the 30. So they said, okay, well, great, that we know you can get a similar benefit, but slightly less side effects at the 10. So that's why we choose based on age, not based on weight or size.
So this one, and Dr. Grindrod, I'm not sure if you are the person to answer this, so you can say not. But someone is asking, what happens if their partner does not want their child vaccinated and they do?
Yeah, I'm not sure that I am the one to ask that. I think one of the things that's probably to consider there is whether that is partners who are married or together, or partners who are no longer partners, because I think those are handled differently. I think that's a tough spot to be in. And I actually think how that has also shown up is people who wanted to be vaccinated who had a partner that didn't want them to be vaccinated. So I think a lot of people and families have been in that situation since the beginning, especially if they're reading different kinds of information or have different risk perceptions. So I don't envy you if you're in that position, because I think that's a very, very hard place to be. One option is for both of you to make an appointment with your family doctor and go in and talk it through. One option too is, that now or wait tool that we designed. We actually designed that with human factors engineers who are specialists in decision making. And often what we're trying to do is not change your mind or get you to shift to another place, but to recognize the position you're taking and to feel comfortable in that position. So even maybe a directed conversation with that. If it's in the budget, a counselor as well can sometimes help with that, just to help navigate that conversation. Because I think right now vaccinations it's a very emotional, very conflicted, very heated topic in some houses. So you might need a bit of a neutral third party, because on the one, the easiest answer is, well, the parent who wants the child vaccinated could just take them in and get them vaccinated. The vaccine team's not going to know one way or the other, but that's not a good long-term plan, because then you just are creating a lot of tension in the future, if the other parent finds out. So that's why that's not my answer. I think it's probably a much more complicated thing, and you might actually require somebody else to be involved in that conversation with you, like a family doctor who can say, I absolutely recommend this, or, you know what, I appreciate, why don't you wait? That might be the right person to bring that to.
Great. Okay, thank you, Dr. Grindrod. I'm going to pass it now back to Jonathan.
Thank you both, Dr. Grindrod and Adele, for going through the questions this evening. As we wrap up tonight's session, I just want to let participants know if there were any questions that we couldn't get to. As I mentioned earlier, you can also submit your questions at any time on the COVID-19 webpage of the Region of Waterloo website. We also have a frequently asked questions link on the website that we continue to update as new questions come in. Or you can call the Region of Waterloo main phone number. So I would like to thank Dr. Grindrod for her time and expertise in answering our many questions related to COVID vaccines. And I want to thank all of the participants for your time and joining us this evening. I hope you found this session informative. Have a good night, everyone.